Hi everyone, this is Neel Raithatha, also known as the Wax Whisperer. Thank you for joining me in my latest video. I have here a couple of cases, and case one is of a patient who attended with a blocked left ear. As you can see, this earwax is extremely sticky, glutinous, mushy, so I've immediately reached out for the medical grade olive oil spray that I use. And what the olive oil spray does, it does several things actually. It helps to bind the wax together. When you've got really loose, wet, mushy wax like this, the oil almost binds it together as it comes out in bigger chunks. In addition, it also helps to line and lubricate the inside of the suction probe. So as the wax is traveling up, it's less likely to get blocked. It's one of the main issues with a wax plug like this. It tends to block as you're suctioning. So I've just, again, put some more olive oil spray in. You're just doing it in layers. So other instruments that you may consider removing this plug of wax with is a Jobson horn, for example. Problem with a Jobson horn in a plug like this is you're going to have to get really deep behind the wax plug, and the wax plug is already past the second bend, and beyond the second bend we've got the osseous portion of the ear canal, the bony part, and that's a very sensitive part of the ear, and quite possibly the Jobson horn, as you can see. If I was to go into that opening and behind the wax, we're very close to the eardrum. A third possible issue with a Jobson horn trying to remove this is because of the consistency, you may just end up spreading the wax almost like a like jam on a slice of toast because it's so soft, loose and mushy. So the olive oil technique and suction, you'll see how well it works, and already I've got half of this plug out, but now that I've got this more lateral part, it's coming away in bigger chunks, as you can see. So it's definitely the approach to use. We've got this residual wax very deep in the ear. It's up against the eardrum, and you can just see the eardrum there at about 4 o'clock, and that's the blue tinge on screen. And again, you've got to be careful with the suction probe not to push it too far in, because you could, just like I mentioned with the Jobson horn, where you may just inadvertently spread it against the canal wall. Even with the suction probe, if you push it too deep up against the wax, you may just compress it against the eardrum, so it can be problematic if you do so. So the key is just to hover over the surface and let's let the suction do the job. Again, you can see it's just blocking the suction probe there. I'm just trying to unblock it, which I managed to do. It just saved me coming out of the ear. Now, this is just all a bit of surface sticky wax skin. If it comes away, brilliant. If not, I'm not overly concerned, but I did manage to peel away the majority of it. This part of the ear canal, the anterior canal walls, so the front section of the ear canal, is slightly protruding. You can see it's almost raised a little bit, so it's protruding towards the midsection of the canal. And that creates a little valley. You'll see the little valley on screen in a moment. Just to the right of the sucker, that's the bottom of the ear canal. So it's quite a bit of a V shape there. You may be able to see that around 4 o'clock on screen. Eardrum looks nice and healthy. Just a bit of staining around the edge, that's non-significant. And I'm just going to mop up near the entrance. They did have quite a wide ear canal actually. So it's a good size to work in. So at least the lateral part, as I mentioned, as we went deeper in the ear canal did narrow. Just going to mop up this excess. So that fine end at the entrance of the ear canal looks really, really small because there's a lot of open space there. And the ear canal is more circular as opposed to oval shape. Most of our ears are oval shaped. This is the same patient. This is their right ear. I just wanted to show you for comparison. So eardrum's intact, healthy, a bit of surface wax at the entrance. We're going to leave that because it's not causing the patient any harm. And in fact, that wax is actually helping and is aiding the patient. This is patient 2. Now, patient 2 wanted me to remove the wax without using any suction at all because they, in the past, when they've had earwax removed elsewhere with suction, it did create short-term tinnitus. So I said, I'll definitely give it a try. We'll just see. What helped me to ultimately remove this without suction is because there's the consistency of the wax. It's a bit drier. So I can grip onto it which I'm struggling to at the moment because of the angle of that piece of wax, but you'll see what I'm going to do. I'm going to reposition that with a St. Bart's ear hook in a moment. If this wax is really mushy and sticky and up against the eardrum, then it's going to be near impossible to remove without using suction. So we're fortunate in that respect. Just got a St. Bart's ear hook, and what I'm going to do is just turn this and just position it slightly differently. And I'm hoping the front edge is a little gap there, which I've created. That's now going to allow the perfect angle to me to glide the bottom jaw underneath the dry wax and skin. You can see there's a couple of pimples in there. I suspect the patient's been poking in their ears and just abrased the outer layer of skin at the entrance of the ear canal. So it's just a bit of a pimple there. So nothing to be concerned about. There's a couple, just a bit of dry skin on the posterior canal wall. Just peeling that away, and fortunately we were able to remove this wax and dry skin mechanically without any microsuction. Same patient, this is their right ear. So this was, you can see where they've actually pushed in and poked in, and I'm entering that space with the St. Bart's ear hook. And this has been compressed against the canal wall. So I'm going to go underneath it now with the St. Bart's ear hook and lift this up. You can see just how adhered and squashed and compressed it was. And now that I've raised it from the floor, I'm going to go back in with the forceps. I can get a good grip. I'm going to just wriggle and tease this out. Still a bit of dry wax keratin, which is matted as well. This is a few hairs, and that's always a telltale sign that a patient has been using cotton buds, because these hairs should be on the outer third of the ear canal. If they're loose like that, they've been pushed in. Of course, these hairs do come out and are replaced by fresh hairs, just like the hairs on our scalp. But that's quite deep, especially the bit on the right. So just re-instructed the patient to, there's an old saying and it still applies, never put anything smaller than your elbow in your ear. So we're going to protect our ears. They're very delicate, sensitive organs, and they can be easily traumatized. So I've just used the hook to separate that. Just a little bit left on the floor of the ear canal, on the posterior canal wall. So I'm going to revert to the Jobson horn, trying to get in and behind. I want to avoid making contact with the canal wall, so because that's on the bony part of the ear. So you can see the difference in consistency between patient 1 and 2. Patient 2, the consistency allowed me to use other instruments, whereas patient 1 is a lot more difficult. Just a bit of skin there. I was going to just reposition that back onto the canal wall. So as it starts to migrate, it's in the correct orientation. So hopefully that won't cause any issues and it won't build up. If I was going to use suction, I would have maybe just try to peel that away to see if it came away without any resistance. I hope you enjoyed that little compilation, guys. Take care, keep well, and speak soon. Bye.